Okay, so happy Friday, everyone. Thank you for joining us. My name is Amy Harris. I'm the manager of the Patient-Centered Primary Care Home Program. And this is our webinar series about the 2025 revised recognition criteria that will be implemented starting in January. So today we're going to be talking with you and describing standard 5A, which is population data management. And this is a standard that received some revisions in the for 2025. So we'll be going over those. And then we'll have plenty of time at the end for any questions that you might have about this standard, as well as if anyone's interested in sharing. Maybe you've already started implementing it. I know that some practices are getting a jump start on some of this work. And so if you've started implementing this standard or some changes to the standard, we'd love to hear how that might be going for you, or if any questions you have about that as well. So I'm going to turn it over to my colleagues to talk about the standard.
Thanks, Amy. Good afternoon, everyone. My name is Amber Anderson, and I'm the lead improvement specialist with the Patient-Centered Primary Care Home Program.
Hi, and I'm Becky Velasco, a verification specialist with the program. Thanks so much for joining us for our webinar on PCPCH Standard 5A, Population Data Management.
So first, we're going to cover just a few webinar logistics and Zoom etiquette reminders. The webinar will be recorded and uploaded to the PCPCH program website. If you're having any technical difficulties, please private message Amy Harris for any help. If you feel comfortable, please have your camera on and put your name and organization information up. Any questions or comments you have can be put in the chat, and we will answer them during the question session at the end. Here is our agenda for today's webinar. I'm going to start by providing a brief overview of the 2025 PCPCH recognition criteria. Next, we will deep dive into PCPCH Standard 5A, Population Data Management. Next, we will share additional PCPCH resources and upcoming learning collaboratives. And lastly, we'll have some time for your questions. So the Patient-Centered Primary Care Home Program was established in 2009 by the Oregon Legislature as part of the state's broader health system transformation strategy to improve access to care, reduce costs to patients, and improve population health. The standards are developed in partnership with an advisory committee and have been revised 5 times since 2009. The 2025 PCPCH standards were developed to support OHA's strategic goal of eliminating health inequities by 2030. The standards specifically help primary care practices build their capacity and processes to address inequities in their patient population. All practices applying or reapplying for PCPCH recognition after January 1st of 2025 must meet these new standards. For more information, I would encourage you to watch the recording of the 2025 PCPCH Standards Overview webinar, which is available on our website. I'm going to take a dive into the overview of Standard 5A. So PCPCH Standard 5A is in Core Attribute 5, Coordination and Integration, which from the patient's perspective means help us navigate the healthcare system to get the care we need in a safe and timely way. The intent of Standard 5A is that in order to coordinate and manage care, a primary care home should be able to produce, track, and proactively utilize health-related information about its patient population. Practices should demonstrate an ability to use this data to proactively manage a population of patients with a specific disease, healthcare need, or health-related circumstance. In the 2020 TA guide, this is a check all that apply standard, and you are able to get a maximum of 15 points. In the updated 2025 TA guide, this is going to be a progressive standard, which means practices can select one measure level that best describes their best describes their practice with a maximum of 15 points. Measure 5A1 requires that the practice uses data on its entire patient population to track overall health needs or engage in proactive patient population management. It is worth 5 points. Measure 5A2 requires that the practice stratifies its entire patient population according to health risk and is worth 10 points. Measure 5A3 is a new measure in the standards of 2025 TA guide. It states that the practice stratifies its entire patient population according to health risk and by at least one health-related social need or demographic category. This measure is worth 15 points. As I said, measure 5A3 is a new measure in the standards for the updated 2025 TA guide. After meeting with community members, our advisory council, and our health equity consultant, Ignatius Bow, it was decided that adding a measure focused on risk score and health-related social need or demographic category could further help practices to proactively manage a population of patients with a specific disease, healthcare need, or health-related circumstance.
Thanks, Amber. Now let's take a deeper dive into each measure in this standard. I'm going to start us off with measure 5A1. PCPCH uses data on its entire patient population to track overall health needs or engage in proactive population management. A practice is meeting measure 5A1 if it generates, analyzes, and uses up-to-date data on its entire active patient population for patient management or tracking of a particular disease state or healthcare need. Patient management implies that a practice is actively monitoring the healthcare needs of a subpopulation of its patients and seeks to identify and correct gaps where indicated care has not been given. Here are a few examples of what this could look like implemented in your practice. A practice generates an inclusive list of patients in the practice who have a particular health behavior to target health promotion activities. This might look like smoking, obesity, hypertension, or uncontrolled diabetes, or patients who need follow-up. Another example is a practice maintaining a registry of patients with diabetes or asthma and tracks the percentage of patients that are up to date on indicated care and testing, like A1C, imaging, or consistently taking their medications appropriately. The current 2020 specifications for this measure require that the practice generate reports on patient demographics. This will no longer be required for this measure, as it has been moved to a different measure in the 2025 standards. As you're completing your PCPCH application, we strongly recommend you gather and save all documentation that would be needed for a site visit. At a site visit, you would be required to show this documentation to the PCPCH program to demonstrate you are meeting the measures. For measure 5A1, you would need to provide documentation of patient lists generated by the practice that are used to track and proactively manage patients with specific conditions or healthcare needs, such as mammograms, well child appointments, or A1C labs. Now let's review measure 5A2. PCPCH stratifies its entire patient population according to health risk. A practice is meeting measure 5A2 if it implements and uses an evidence-based risk stratification process for all its active patients to identify those at greater risk for developing poor health outcomes. It's critical that the risk stratification process include patients of all ages who receive primary care in the practice. The practice must be able to describe its process for regularly reviewing the risk stratification assignments for its patient population and can adjust risk scores as needed. Here are a couple of examples of activities that demonstrate successful implementation of Measure 5A2. The practice uses a risk stratification strategy for its patient population based upon disease states, psychosocial risks, and special healthcare needs, such as those of children with unique healthcare needs. This approach helps to focus interventions, care coordination, and care planning resources for their patients. And another example, the practice utilizes an evidence-based tool or process to stratify their patient population based upon health risk and can provide lists of patients and their risk assignment. At a PCPCH site visit, you would need to provide the following pieces of documentation to demonstrate you're meeting Measure 5A2. First, a policy, procedure, or workflow that demonstrates how the risk stratification process is implemented by the practice, including the criteria used to determine each level of risk. And you'd also need to provide de-identified lists, registries, or trackers demonstrating how the practice is tracking patients who meet the criteria for selected risk stratification categories.
Thanks, Becky. Now we're going to take a look at the new Measure 5A3. A practice is meeting Measure 5A3 if it is meeting all of the specifications for 5A2 that we just discussed and incorporates at least one health-related social need or demographic category into its risk stratification system. Demographic categories may be defined by characteristics such as race, ethnicity, language, disability status, gender, gender identity, sexual orientation, age, social class, geographic region, life circumstances, or other characteristics relevant to the practice's patient population. Here are two examples of how you could implement this measure in your practice. The practice implements a risk stratification strategy for its patient population based upon disease states, psychosocial risks, special healthcare needs, and language to target interventions, care coordination, and care planning resources most effective for their patients. The other is a practice with a significant homeless population, stratifies its entire patient population according to health risk and housing instability status to ensure that care strategies consider this need. For example, many patients experiencing housing instability have a higher risk score than comparable patients without housing instability. Again, as you're completing your PCPCH application, we strongly recommend you gather and collect all documentation that would be needed for a site visit. At a site visit, you would be required to show this documentation to the PCPCH program to demonstrate you are meeting the measure. The two documentation requirements include a policy, procedure, or workflow that demonstrates how the risk stratification process is implemented by the practice, including the criteria used to determine each level of risk. This must include both a health risk and at least one health-related social need or demographic category. Next is de-identified lists, registries, or trackers demonstrating how the practice is tracking patients who meet the criteria for those selected risk stratification categories. The PCPCH program is hosting this webinar series to assist practices and other community partners in understanding the standards. Webinars are scheduled every other Friday through the end of December. You can find a complete list of topics and registration information on our website. The next 3 webinars are listed here on this slide. I hope you'll join us, but webinars are recorded and will be posted on our website if you can't make it. This final slide is additional resources that you may find helpful. The first is our PCPCH program website. The second is the 2025 TA guide with detailed information about how to implement every measure and the documentation requirements. Next is a link to our TA resources webpage. And finally, the community engagement report and evaluation. Lastly, you're always welcome to reach out to the PCPCH program with any questions through our program email. So that concludes our website, our webinar on Standard 5A. Thank you so much for joining us. And now we will go through some of your questions in the chat.
Great. Thank you so much, Amber and Alicia, for that presentation and overview of the new standard or revised standard. So as Amber said, we're going to open it up to questions, and it looks like we have a couple in the chat already, which is great. Let me just move those out. Okay. So the first question is, our practice uses a risk algorithm, AAFP, risk stratified care management and coordination, that designates the complex patient who is scheduled for longer visits and more frequently. Does this meet the requirements for 5A3? So we would have to take a closer look at what that risk stratification algorithm is that you're using during a site visit. If we were to do a site visit, we can't say for sure whether it would meet the measure. We'd have to take a look at it. I would actually look to my colleagues to see if you are familiar with that particular risk stratification algorithm that's being used, and you could speak to it. Again, we wouldn't be able to confirm for sure if it would meet the criteria, but I'm curious if any of my colleagues are familiar with that, and if you have any comments or feedback.
I'm not familiar with that particular risk stratification strategy. And I guess it would depend on what categories are used to designate a patient as complex. Mm-hmm. So we would have to look at those categories to make sure that it met the criteria of a health-related social need or demographic criteria, along with whatever you're using to identify like medium, low, or high risk patients.
Okay. Thanks for that, Amber. So the next question is, what are some evidence-based risk stratification tools? Gosh, I'm having a hard time getting those words out this morning. Evidence-based risk stratification tools. Say that 5 times fast. Okay, so that's a great question. Again, I'm going to defer to my colleagues. I know that there are lots of different ways that practices risk stratify patients, including their own internal strategies that they develop. And in terms of evidence-based strategies, I would turn to you folks, to our team, to see if there's been anything that you've seen in practice that's being utilized that has a strong evidence base behind it.
Well, we do a lot of site visits at clinics that have Epic, and Epic does have, and other EHRs do have built-in risk scoring algorithms, which take into account age, gender, disease state. I think you can set the parameters of what you want it to look at. As far as evidence-based strategies, we do have some in the TA guide under the measure 2 or 5A2. We have a couple listed in there that you could use. There's also some information on, I think, some trauma-informed way of doing that risk scoring as well in the TA guide. We want to see that patients are given a category and that there's a meaning to that category, and then you do something with that. So if you have a low, medium, high, That could be based on, your low risk patients might be your younger patients who are pretty healthy that don't need a lot of, maintenance or care coordination. Your medium patients might have maybe 2 diseases, maybe one health-related social need that you're looking at that puts them in a medium category. Your high-risk patients might be those high utilizers of the ED, 3 or more comorbidities, a housing insecurity and a language barrier. Those are your folks that are really your, small percentage of your highest risk patients that you're doing more care coordination for, you're doing more outreach for those patients. They might be seeing a lot of specialists, so you're more involved in their care and they're higher risk or a more complex patient than your average, 22-year-old who you got to drag into the doctor. So that's, kind of, I think, a very basic high overview way of how you can risk stratify your patients, but then doing something with that. So, in the chat, it says something about complex patients are scheduled for longer appointments. So that's something you're doing different for those higher risk patients than you are your low risk patients. It might be that you're checking in with them every 90 days. And when I was in clinic, my high risk patients were my diabetics with an A1C over 9, and I was checking on them every 90 days to make sure they had their A1Cs, make sure their foot exams were done, making sure they had their eye exams. Those were all things that I did for my high risk patients, and it was categorized by their A1C being over 9. So there's a lot of different ways that you can risk stratify your patients, how you can identify those patients and what they need higher care for. And then also your whole clinic knowing about your risk stratification, what it's for, why we do this, what it's used for, why care coordination folks maybe are working more with the high risk patients and not the low. Sometimes we go in for site visits and even the providers are like, I didn't even know we did risk scoring. and we have a lot of other staff talking about it, or a lot of documentation to support and demonstrate that yes, there is a risk scoring process, but the providers don't know about it. So just that overall education throughout your whole clinic and practice about what this risk score is for, why we use it, and what it means.
Yeah, and thank you for adding that, Amber. And again, I also want to just mention that that the risk algorithm that was put in the chat from Randa, actually is in our TA guide as well. So the AAFP risk stratified care management and coordination, that's actually in our TA guide listed as a resource. And it looks like she also says it, or that person also says it's great. So that would be one that folks could explore as well for that patient population. And then the other thing too that I just want to quickly emphasize is that this standard is really about the data and how you are managing your patient data. We won't be asking you for data on how you're using it. We just want to see that you have a strategy for using it, if that makes sense. So in many ways, this standard complements other measures and standards that are in the model. A lot of the standards that we have require you to use data. And so this is really about how you're risk stratifying your patients and how you are utilizing, or how you are doing that data piece to again complement other standards that are in the model. So let's move on to some of the other questions. So it would be nice to know ahead of time what the requirements are for the risk stratification tool instead of guessing and hoping it would pass. So again, I just want to restate that we aren't looking for you to use a specific risk stratification tool. We're looking for you to meet what we say in the specifications around the category. So again, whatever tool you're using to meet 3A or to meet 5A3 does have to include some kind of health risk and some kind of either health-related social need or demographic category. So again, and then figuring out how you're acting on that. What are you doing with that? We're not necessarily looking for you to use a specific tool, just that you have a process in place for risk stratification and that you're taking those things into consideration and that you're doing something with it. So, if you have a question about a specific strategy that you're using or a tool that you're using that you want to run by our team, reach out to us and let us know. You can email the inbox, you can give us some information about it, some more details. We can let you know if, yeah, that sounds like you're probably doing it. Again, we can't say, we can't verify that you're meeting a measure for 100% certainty until we actually do a site visit, because the way that sometimes practices describe stuff to us isn't actually what we see when we get to the practice. So we can't, but we can give you a pretty good idea. We can say, yep, that sounds about right, or it sounds like you probably are on the right track with that. So if you have a question about your specific tool or your strategy, reach out to us. We know risk stratification is there's a lot of variability in how practices do it, and it's pretty complex. And so if you have any question at all about what you're doing, reach out to us individually through the inbox, and we can definitely help you and help you and try to give you some clarity around your specific tool that you might be using. So yeah, that's a good question. Let's see. Oh, and Meg dropped that in the chat. Thank you. Okay, so as a pediatric office, a lot of these are skewed towards adults and don't make a lot of sense. We don't have a very solid risk stratification workflow, but it's frustrating not to know if it's going to meet your evidence-based criteria. So again, what I mentioned before about the tool, we're really just looking to make sure that you have a way that you are risk stratifying your patients for this standard. And again, if you want to reach out to us and talk to us about what you're doing, we'd be happy to talk with you about your specific strategy for sure. Let's see. So here's a tip. Another helpful tip is that we add a fake ICD-10 code for stratification levels. So S00.1 is level 1 up to S00.6 level. And that's how they track their levels. So sort of a fake ICD-10 code. That's interesting. I don't know if anyone else has ever seen that in practice or done that.
Amy, I have not, and that's really cool. Congratulations. I think that's a super smart way to do it, because 1 through 6 is the typical, range that we see, 1 being the lowest risk and 6 being the highest risk. So congratulations. That's really cool. Thank you.
Looks like you have a couple of thumbs up on that too. So, so good suggestion. Okay, so it looks like Charlene says maybe you're getting hung up on the wording of evidence-based, but it sounds like we can only use a pre-validated tool. So no, that is incorrect. You do not have to use a pre-validated tool. So and if we have evidence-based in the TA guide language, then, which I don't know if we do, if it says evidence-based tool
in 5A2.
Okay.
And I think what it's getting at is we don't want you to be stratifying your patients on their eye color or, it needs to be an evidence-based health related risk stratification process, not something really, if you're choosing.
Yeah. So I think maybe we need to take a look at removing that evidence-based qualifier or adjective for that, because I think that does mean something different than how we are intending it to mean. A lot of people do think it means a validated evidence-based tool, and that's not what we're looking for this measure. So I apologize, Charlene, if that's what's tripping you up. And I think we need to take a look at the TA guide and think about removing that. And so I don't know, Rachel, if you could make a note for that, because if you're having that question, Charlene, then certainly other people are as well. And that contradicts what we're saying here on this webinar. So, and it contradicts our intent of the standard. It doesn't have to be an evidence-based tool. It could be however you're doing your risk stratification. So I think we need to probably take that off. So thank you for pointing that out. And now I understand why you are confused.
Well, we do have a definition. I will say this is one of our measures. We do have definitions in this standard, and risk stratification is in the definitions section as well to help clinics kind of identify that process. So I don't want to read the whole, description right now, but if you go into the TA guide under this measure, there is definitions on what health-related social needs and risk stratification is. So that can help kind of bridge that gap between what we're kind of trying to get at and what clinics might be understanding. That's why we added those definitions on some of the measures.
Yep, I just dropped it in the
Perfect.
chat for folks.
Good.
So, yeah. Yep. Good. Okay, so let me go back. Let me roll back up to the questions. Okay, so Deborah says we utilize a specific pediatric tool to stratify the pediatric. Okay, great, perfect. Thank you, Deborah. She's going to reach out to us. Oh, that's helpful. Thank you. Good. Yes, we will definitely remove. Yeah, you're right. Evidence-based does mean a lot. You're right, Charlene. I mean, I think we throw around, we like often see that term related to health and medicine, and it can mean lots of different things. So, so for us, it does not, I think we have two different meanings of that. Okay, so here's a question from Robin. Is there still a requirement that the risk score can be manually adjusted? We have some really amazing tools built into Epic, but often the scores are assigned based on the tool's methodology and cannot be manually overridden, though they're automatically updated as the patient's conditions change over time. Restore. So that's a good question. I'm actually going to defer. I'm not as familiar with this as our site visitors. So I'm going to turn it over to one of our team to respond to that. Or even, I know one of our newest team members, Meg Bowen, worked at Ochin.
I knew you were going to call me out.
So I know. And so she probably can answer that question like that.
Yeah. So I'm not aware of any way that you can modify those HCC risk scores that happen in your population health management tool that goes along with Epic, whether you're using Compass Rose or it's probably what you're talking about. It used to be the Charleston, but now it's HCC. So I don't believe that there's a way to do that because it does pump in all the information from the encounters of what's happening to the patient. So, and I don't know that that is a part of this measure, that it has to be able to be manually updated. Is that wording in there?
No, just that it's being adjusted accordingly.
Yeah.
So if your built-in EHR system is adjusting scores according to the happenings of your patient, then that is automatically happening and you don't need to worry about that.
Yep.
Way back in the day when I was in clinic and we were doing it manually, I took a list of high-risk patients to my doc each week and said, these are your high-risk patients coming in this week. Are they still, they haven't been in the hospital for the last 90 days. Do they still need to be high risk because they were high risk because of their hospitalization, but now they're good, or, they're working with their specialists, and maybe we can bump them down from very high risk to high risk. So that was that manual adjusting that was happening because we didn't have an automated way of that happening. But it's not a requirement.
Not a requirement. So enjoy that. You folks that have Epic, sit back and watch that magic happen for you.
Thanks, you guys. Robin says thank you. Other questions? I think that's, let me just, oh, okay, nope, got another one that just came in. So in the Epic risk score, there is a way to complete a risk interpretation to low, medium, or high. It doesn't change the actual risk score, but allows for a risk interpretation, at least for the instance of Epic we have.
That's awesome. So what I'm understanding is that this patient could be a 6 in your registry, but you can adjust that down because you have a different set of knowledge about that patient. You can adjust that patient down to a medium risk and not, be a 5-alarm fire with that patient. Is that kind of what you're saying? It's kind of a nice approach, to have a clinic be able to customize who they really feel are the critical or the most critical patients to follow. So yeah, great.
Yes, it sounds like that is what that person is saying. So great. Oh, great. Thanks for sharing that too. Other questions or comments?
This is Randa here. Can you hear me okay?
Yeah, yeah.
Initially, I found this standard very daunting. And I found the AAFP, the Risk Stratified Care Management and Coordination Tool, very helpful, but I was really unsure how to actually get it going. So I sat down with my brother-in-law, who is a retired physician, and we would go through one patient at a time to stratify. And it took me a while at the beginning to wrap my head around using this tool. But now it's become really intuitive. And this tool goes from level 1 to 6, and level 1, so for even the pediatric clinic could be very helpful because level 1 is healthy. Level 2 is no known diagnosis, but a risk factor such as an elevated BMI or a smoker. Level 3 is chronic conditions, but doing well at goal, like A1C is where it should be for a person with diabetes. Level 4 is moving more into the unstable range, like high level of depression, morbid obesity, one emergency visit, one hospitalization in the past year. So it gives very clear guidelines. Level 5 is a complex patient, which is 3 or more active chronic conditions or high-risk social determinants of health, potential of dying or being institutionalized in the next year. And I really like having my complex patients identified because it would just be a feeling. Oh, this person is complex. In my assessment note, I would say complex, but now I can actually see it. And then level 6 is the potential of dying or being institutionalized in the next year. And also another really helpful use for stratifying patients is when it starts feeling really heavy in clinic, that I've got a lot of complex patients, I could literally run a report to look at the S00.5 diagnoses and pull them out. It's like being a staff nurse in the hospital and getting a number for my acuity of patients, and then we're assigned what is appropriate. And I used to work in risk management in a hospital, and I also find this is a safety strategy for clinics. I'm a solo provider, and when it's getting to be too much, that I can talk with my office staff cadence and say, you know, we've got to come up with a plan for this. So just wanted to say it was intimidating at the beginning, but I really like this tool. And as soon as a patient comes in, I'll think, oh, this is a level 3 or this is a level 5. So just wanted to say it's hard at the beginning, but it gets easier.
That's great. And I thank you so much for sharing that, especially as a solo provider. I think solo provider practice, I think sometimes you know, some of our measures and standards feel unattainable for solo practices. And so I really appreciate you sharing your experience with this tool. We actually are planning to put together in the beginning of the year in 2025, after practices have started implementing these measures a bit more, we are going to put together some learning collaboratives that are less driven by our team talking about the standards and more driven by practices sharing how they're implementing it. So we might reach out to you because we always like to hear how solo practices or solo provider practices are implementing our standards and ways that they are and tools that they're finding to be helpful. So we might reach out to you. So thank you for sharing that. So great. Oh, and thanks for doing that. Great. Thank you. Do other folks have questions or things they want to share? You can also ask about other standards and measures as well. I should have said that at the top of the hour, although we are focusing on 5A and our population data management. We also, if something else has come to your mind over the last couple months as we've been doing these webinars, or as you've been digging into the standards a bit more, you can definitely ask us other questions about that as well. We also will be doing some office hours as well, sort of open office hours as we move into 2025 for that purpose as well. So for just general questions. Okay, looks like there's a question here. It looks like it's to the group, which is great. How do other members document outreach in Epic? We use lists and sticky notes for health reminders. So that's a good question. I don't know if anybody wants to, anyone on the call who uses Epic would like to answer Jacqueline's question about that.
Hi, this is Danny from Farm Workers. The way we typically track encounters or outreach in Epic, we have what's called an outreach encounter. And it's set up in the way where you can pick the topic, right? So depending on what it was for. But it just looks like a telephone encounter. It's just specific to outreach. And that's how we were able to track it. And then there's different ways to do the outreach. We have the option of doing a text, phone call, mail, or letters. We don't do as much, but that's still an option. You can also do it through MyChart. And if you send a message through MyChart or you do the encounter, it'll be in the patient's chart for others to see.
Great. Thank you for sharing that, Danny.
Do you keep that encounter open, Danny, and like add new times each time you do a outreach for the same person for the same?
No, we do.
Sure.
It's excuse me. We close the encounter after they do that one specific outreach. We have reports on our end also, where we track the outreach monthly, or at least I do, and then we send that out to our clinics so that they can also see, right, the efforts that they're doing. But the way we have it set up is it's one outreach encounter per outreach, if that makes sense.
Thanks.
And it looks like there's a follow-up question to that from Jacqueline is, how do you show that for a site visit? Is it, so that would be a site visit from the PCPCH program. Is that a downloadable list? So I guess I'd ask our site visit team. Screenshots maybe? Or can it be downloaded? Or rather a report probably run on it? Meg, I see you nodding.
Yeah. Yeah, you can run a report on that. You can also take screenshots of those encounters. Yeah, those would both suffice.
Okay, thank you. I was going to
You're
ask
welcome.
Alicia because it's like we have the
Oh.
list, but then they're using
Yes.
sticky notes. So I was like, do I take a screenshot? Like, how do I
Yeah.
make those two things match up, right? And so
Yeah.
thank you. I've been really struggling with that this
Yeah.
week.
So if that's
Good.
your process though, with using the sticky notes, you can, just take snapshots of the sticky notes that are open and your process that when you see a sticky note, everybody knows to open that sticky note and
Yes.
use different colors for different roles yeah. Awesome.
Okay, yeah. This was new to me. They changed
Oh.
from the time we attested to now, they changed how they did it, and I just learned about it this week. And so I'm trying to provide documentation for a site visit we have in a couple of weeks, and I went, uh-oh, now what do I do? So thank you. Thank you, Danny, and thank you, Meg.
You're welcome.
And you're always welcome, of course, as you know, to reach out to Alicia, who's on our team and is your site visit.
Yes.
I just found out. Yes.
I just found out yesterday. Yeah,
Great.
so I was going to email
Perfect.
her after this. Yeah, thank you.
Yeah, of course, of course. Other questions folks have, or either about this or other standards, some other standards? Well, I'm not seeing anything in the chat and nobody's unmuting. So I think we will wrap today's up. I just want to, again, thank everyone for coming and attending. And your great questions and the conversation. As I've said before, if you've attended other webinars that we've done in this series, the questions that you bring to these webinars are very helpful for us, and they help us. They help us really refine some of the technical specifications. So the question about the evidence, or the comment about the evidence-based, that makes total sense. And we totally understand why that would be confusing, and we'll take that out. You know, we work really closely with providers and office administrators and quality improvement folks to help us draft these standards, but we don't always get it right. And, you know, and when we're doing the tech specs. And so these questions are really helpful for us. And then in turn will be helpful for other practices. So again, if you're ever struggling or things just don't make sense to you, you know, definitely bring those things to these meetings and these webinars, but also reach out to us, because it could just be something like where just what I described with the idea with the qualifier of the evidence-based tool, like that's not what we meant. And so really getting that additional clarity if something seems challenging or doesn't seem quite right for you or to you, let us know, because that's how we improve the implementation. That's how we improve the technical specifications and make it better for everyone. If you're struggling, someone else is struggling too. So always feel free to reach out to us. And Rachel, who you see on the screen, she's the one who answers all of our emails and our phone calls. If she doesn't know the answer, she reaches out to the rest of the team to get it. And she's super prompt. She's very quick. So definitely make sure that you're reaching out to us. So again, thank you so much. I hope you'll join us for the next time. And have a great weekend, everyone. Happy Friday.
Thank you. Bye.
Bye.